Hello, I'm Matthew Weinstock, reporting to you live from the Health Forum American Hospital Association Leadership Summit in San Francisco. I'm delighted to be joined right now by Dr. Atul Gawande, who just gave a very thought-provoking keynote address to kick off this year's summit. Atul, thanks for being with me today.
Thank you.
So your address this afternoon, or Thursday afternoon, really seemed to focus on challenging CEOs in the crowd, as well as other parts of the healthcare system, to rethink how care is delivered and organized.
Well, what I was talking about is this paradigm shift where we think of ourselves, make a shift in thinking of ourselves as delivering stuff. We deliver pills and surgery and specialists, and to really think of ourselves as delivering outcomes. And that's an unusual place to be. We really, we're in a world not so long ago where you simply hire the doctors, leave them alone, and they do what they do to get the best possible outcomes. But we have learned and are seeing lots of ways in which, whether it's the simplicity of do we have the right infection protocols in place and you can get rid of certain kinds of infections, to, do we have really good care for people at the end of life, and everything in between. That's a new place for us, but the challenge is that the public expects us to be able to deliver a uniformly high standard of care. And that is the ambition that we are taking on when we say we are growing our systems, we are merging and acquiring and expanding because we really think we can deliver better outcomes of care.
And one of the things you talked about in your speech was the idea that Ebola really put on the front line for CEOs, that it is their job to start thinking about how doctors put on their gowns, how we follow infection prevention protocols.
Yeah, and it was a very, I think, unusual reminder. Ebola hit the country as a kind of tidal wave of fear, and the fear was stoked by concern in the public that we as health professionals really didn't know what we were doing, that we didn't even know how to put on gowns and gloves to keep from spreading infection to one another, let alone between patients. And we learned how to execute. We did a great job in being able to now contain Ebola when patients landed here. But it was like a huge fire drill, because we had never, as institutions, really tried to take on this kind of tight expectation of high standards of our care. It was a crisis, I think, for many hospitals. We all looked at what happened in Dallas when one patient was discharged prematurely, then came back, and then 2 nurses ended up infected with Ebola, and realized we weren't prepared and that our systems needed to, we had, as groups of people, needed to take accountability for the results rather than just expecting that individually everybody would just do the right thing.
Right, and this idea of groups of people, of team, is something you also talked about, and you talk about in your book, Being Mortal. The idea of end-of-life care really needs to be more team-approached, right, team-oriented, but also talking to the patient, asking the patient, what do they want, what are their fears, what are their wishes?
Yeah, what drops through the cracks between all of the people who take care of people facing serious illness or with serious infirmity was something that I didn't realize as in my practice. I felt very good at taking care of the problems that I could fix, but I felt, almost incompetent at being able to take good care of people whose problems I was not going to make go away. People at the end of life, people with increasing problems that are really due to just frailty as they get older. And what I found from this investigative process of interviewing more than 200 patients and family members about their experiences with these kinds of situations was that there are some clinicians who do an unbelievable job. And what they recognized that I wasn't recognizing was just a few things, that people have priorities in their lives besides just living longer. The only way to know what those priorities are is to ask them. And we aren't asking them. And I realized I wasn't asking them. In my routine office visit was I talked 95% of the time. I gave them lots of facts and here are the options you have in front of you, and you have option A, option B, option C, and here are the risks and here are the benefits and here's your situation. And then they'd say, so then what should I do, doctor? And I didn't have clarity about how to answer that question. Then I understood if I asked them, what's your understanding of where you are with your condition? What are your fears and worries for the future? What are your goals and priorities if your health worsens? What are you willing to go through? And what are you not willing to go through for the sake of more time? Those kinds of questions. One patient said to me, I'm willing to go through a lot as long as I can still read a book at home. I talk up the story of another man who said, as long as I can eat chocolate ice cream and watch football on television, that'll be good enough for me. And that's like the best living will ever. And now I know what I can recommend. Yes, this has the best chance of you getting to have the life that you still would value, or this won't, and therefore we should take this other path. That is the transformation in thinking I felt like I experienced. Once I understood that that was my job, it really changed the way care went for my patients. And it also changed the way care went for my family, even my dad, who died of a brain tumor.
For a CEO, though, how do they start to think about this and help their clinicians get to the point where you are?
So one of the things that we've then begun as an experiment is we're working at the Dana-Farber Cancer Institute and the Brigham and Women's Hospital for how do you deploy this as a kind of population management program for all people with serious illness. And what we did is we went to the palliative care department and we said, instead of just being responsible for the people who are who are sent to you to consult on them, often too late in the game, what if you took responsibility for monitoring how many of our clinicians are asking these questions, and then trying to make sure that these conversations happen more, earlier, and better. And then we made a system where they are training physicians in a 2-hour training program for how to have asked the core 7 questions that palliative care doctors ask. It's been widely supported, extremely popular. We're seeing marked increases in the number of patients who have these conversations and have them earlier. We're studying right now what kind of outcome differences that makes. But what we've seen in studies of people who receive earlier palliative care conversations and planning, that they often make choices to stop aggressive therapy sooner. They have more days at home, fewer days in the hospital. They have less suffering at the end of life, and they actually live longer on average, which is the amazing thing.
And so lastly, Atul, the thing I want to ask you is, part of the theme too of your speech today was the idea that there's some there's some pain now for gain later in the system as we go through some of these innovations, as we say. Talk a little bit about that there's going to be pain now for the provider system, hospitals, for longer term gain.
Well, so the hardest things to get to spread in our system are the discoveries that are painful or difficult for teams to execute on, but they're really good for patients. The ones that are, as I described it, really good for the patient and good for the doctors, move incredibly fast. I talked about anesthesia, for example, which was great for the patient, but it was also great for the doctors who didn't have people screaming in pain on the table, right? I talked about Viagra having an immediate and valued effect for the patient, and became one of the fastest selling drugs in history because it was also brought patients to urologists and they were thrilled to see them. By contrast, getting high blood pressure under control and having the repeat visits and the careful oversight of patients to make sure that blood pressure is being successfully managed, or being able to deal with really complex, critically ill patients who require a lot of coordination among multiple specialists. Doing that work, increasing communication, making sure that everybody understands their roles and responsibilities, really connecting to the patient in their home environment. Those are hard to do, they're painful to do, They have extraordinary benefits upstream, and being able to deliver on those kinds of capabilities make it easier and easier for teams to do this hard work. That's going to be where huge value comes from for the patient and ultimately for the teams. And we're in this space right now where taking care of complex patients is actually harder. We don't love the computer systems. We find everything a kind of difficult uphill battle. And we're in this transitional phase where just making that easier and easier is going to be the opportunity that now is there for us.
Atul, I appreciate your time today.
Thank you.
And I'm Matthew Weinstock with Hospitals and Health Networks. Thanks for tuning in.